Good day, everybody. This is Chris with the Ancient Scholar, and today I'd like to talk about the third major class of antidepressants, also known as the monoamine oxidase inhibitors, or the MAOIs, and these include medications such as phenelzine or Nardil, isocarboxazide or Marplan, and others. Like the tricyclic antidepressants, these are a very old class of medications. They're some of the original antidepressants that were developed and used in the 1950s and have largely fallen out of favor due to their side effects profile. So let's go ahead and just talk about the MAOIs. So the MAOIs inhibit an enzyme known as monoamine oxidase, or MAO. And monoamine oxidase, along with another enzyme known as catechol-O-methyltransferase, or COMT, are largely responsible for catalyzing the breakdown or the degradation of monoamines. And monoamines, or biogenic amines, are essentially adrenaline-like molecules. These are sympathetic hormones and neurotransmitters such as epinephrine, dopamine, norepinephrine, and serotonin, or 5-hydroxytryptamine. And so these enzymes, MAO and COMT, are largely responsible for the enzymatic degradation of these particular substances. So you can see how it might be useful to develop a medication that would inhibit this enzyme and increase the level of monoamines that you have within your body, particularly the brain. So you can increase serotonin levels, norepinephrine levels, dopamine levels, and so on. And this can then possibly be used therapeutically to treat mood disorders, depression, anxiety, etc. So that's the main mechanism of action of the MAOIs, and in fact there are actually two types of monoamine oxidase, two major types. There is something called MAOA, this is monoamine oxidase A, and this is primarily located in the GI tract. We have a substantial amount of this in our gut, and this is also located within the brain, within the central nervous system, within serotonergic neurons. So that's MAOA, and then there is also MAOB, or monoamine oxidase B, and this is primarily located within dopaminergic neurons within the central nervous system. And MAOB is not as substantial as it's not substantially targeted therapeutically for the treatment of mood disorders, but there are medications that selectively inhibit MAOB that are sometimes used to treat certain problems involving these dopaminergic neurons. One example would be medications used to treat Alzheimer's dementia. So when it comes to treating mood disorders, most of the effects that we're looking at are going to be inhibition of MAOA, and so there are monoamine oxidase inhibitors that selectively inhibit MAOA, and then there are others that are non-selective and inhibit both MAOA and MAOB, and they can both be used for their antidepressant properties. So when we talk about MAOIs, there are a couple of, they come from a couple different places. The MAOIs can be synthesized as medications, and there are also some other naturally occurring monoamine oxidase inhibitors that I want to just quickly mention. And I'll give you guys a couple of examples. There is what are known as Harmala alkaloids. And these Harmala alkaloids come from a plant. Comes from the Amazon jungle, and it is known as the ayahuasca vine. The ayahuasca vine, and you may have heard of this. Ayahuasca is the name of a brew that is a brew or a tea-like substance that is used in ceremonies for its hallucinogenic properties. And it's actually a mixture of two substances. There's the vine of the ayahuasca and the bark of another plant. And the bark of this other plant contains large amounts of dimethyltryptamine. And normally, if you were to ingest large amounts of something like serotonin or dimethyltryptamine or some other monoamine, the substantial amounts of monoamine oxidase A in your gut would essentially deactivate all those monoamines. They wouldn't get absorbed, and you wouldn't have a problem. And in fact, many plants contain a lot of these monoamines, and so that's probably why we have so much of this in our gut. But what people have found is that if you mix the ayahuasca vine with the bark, the harmala alkaloids will inhibit the monoamine oxidase in the gut and allow you to absorb the dimethyltryptamine. And then the dimethyltryptamine will then circulate to your brain, and it will cause hallucinogenic side effects. So that's one area where we can see this used. And then the other is a plant that's actually pretty common here in the southwest United States, and it's called a Syrian rue. And the Syrian rue, little flowers that bloom in the spring down in the desert southwest and other parts of the United States. And these also contain alkaloids that are very similar to the harmala alkaloids, and so some people will pick them and use them and brew them into teas and capsules and whatnot, and use their monoamine oxidase inhibitor effects for various reasons. So what I'm going to do is I'm going to focus more on the medication aspect, and more accurately, I'm going to talk about some of the substantial toxicological implications of the monoamine oxidase inhibitors, because they're definitely a very important there are very important toxicological implications. So the most important implication in a toxicological context is a severe hypertensive syndrome that can develop. And this can result from an overdose of these agents, or more often it is really due to interactions. It can be due to drug interactions or food interactions. There are some very specific food interactions when it comes to the monoamine oxidase inhibitors. I will also caveat this, that as is the case with any antidepressant, there is always going to be a risk of serotonin syndrome. And I've already talked about serotonin syndrome, so I won't rehash it here. I'll just put that caveat there that that's always going on in the background. But this hypertensive syndrome is a very specific problem with monoamine oxidase inhibitors. So at the end of the day, if you inhibit monoamine oxidase, any time that you expose yourself to monoamines, specifically sympathomimetic molecules, so these are molecules that are adrenaline or adrenaline-like, right? So if you give somebody, say, adrenaline, or they receive an infusion of dopamine, norepinephrine, or perhaps they illicitly use, something like cocaine or methamphetamine, right? These molecules that have a biogenic amine structure to them, right? If you do that plus a monoamine oxidase inhibitor, right, that really equals badness. That potentially equals this hypertensive crisis that we can see, because the body cannot effectively or is efficiently degrade those sympathomimetic or sympathetic or adrenergic agents that have been introduced in the body. And this also includes indirect agents. This includes indirect sympathomimetics as well. such as really important precursor molecules to the adrenergic agents, and most importantly what we run into is an amino acid called tyramine. And remember, amino acids are a very important component of these biogenic amines, tyramine being one. And so anytime somebody is exposed to a food that is high in tyramine, this can elicit or precipitate a hypertensive crisis, because a patient will be unable to appropriately metabolize the tyramine into less functional metabolites, and that'll become a problem. So what kinds of foods do we see this? So the big foods where we see this, like the classic ones, are going to be cheeses. The more aged the cheese, the worse it is, and wines. So cheese and wine are the really big offenders, but there are some others that you want to be aware of as well, such as yogurt, fermented meats. So you can see fermentation and aging is a very important thing here. Caviar, anchovies, canned meats as well. Fermented soy. And so this includes all the various fermented soy products, soy sauce, tofu, miso, and so on and so forth. Sauerkraut as well. Ripened bananas. Ripe and overripe fruits. Raspberries. And then exposure to molecules that are caffeine or caffeine-like. Caffeine or caffeine-like, so the xanthines as well, right? So theobromine, if you are eating large amounts of like really dark chocolate, caffeine, large amounts of caffeine, or even medications that are caffeine-like, the so-called methylxanthines, theophylline, for example. So any of these can increase the risk of this hypertensive syndrome. So what happens to these patients? So they develop a very high blood pressure, and some other things can happen as well. But it's really, they just develop a hypertensive crisis, really, a hypertensive emergency. And that can result in end organ dysfunction, right? They can develop encephalopathies, cardiac failure. Really a whole variety of signs and symptoms can occur. Seizures may even happen as well, associated with the encephalopathy. So really, really nasty stuff. And so when we look at treating this, right, what are some things? Well, obviously good supportive care, as is the case with all of the kind of managing antidepressant stuff that we talked about. Good supportive care. If they have seizures, of course, our old friends, the benzodiazepines, are going to be the primary agents there. And we really want to get control of the blood pressure, but we need to be very careful in how we control blood pressure. We don't want to give, say, large doses of some oral medications where the absorption distribution is unreliable. We want to be able to titrate control. So IV infusions of easily titratable medications probably going to be the mainstays. So titratable calcium channel blockers, for example, alpha-1 blockers to cause some titratable vasodilation, such as phentolamine, be a good agent. Other vasodilators, such as the nitrates, nitroglycerin infusions, would probably be something that we could use as well. So yeah, the big thing is really going to come down to prevention, right? If somebody's on a monoamine oxidase inhibitor, right, good education to help this person avoid foods which may precipitate hypertensive crisis. So good education obviously is going to come first, and then if they do develop a hypertensive crisis, identify it based on the history and the physical exam of the patient, and then initiating the appropriate treatment. And in addition to that, there are a lot of side effects. So there are a lot of just common side effects associated with the MAOIs, such as xerostoma, also known as dry mouth, obviously nausea, vomiting, diarrhea, which basically everything, insomnia. So kind of the standard antidepressant stuff. They can have agitation, vertigo and dizziness. They can have both a low blood pressure and an elevation in blood pressure. And again, these are just standard side effects that we can get with these. Sexual dysfunction, much like the SSRIs we talked about. Dysuria, difficulty urinating. They can also have muscle pain. They can even get fasciculations. So even just your run-of-the-mill side effects with MAOIs are fairly substantial, let alone the specific toxicological implications associated with the MAOIs. And so that makes sense why the monoamine oxidase inhibitors are not as commonly used anymore. However, they are very effective in some cases, and so what we can run into is we can run into people who have failed SSRI therapy, and they've maybe been on multiple SSRIs without any success, and we've actually had to transition to these older agents, the MAOIs and sometimes the TCAs, in order to help treat their depression. And so we might occasionally run into somebody on an MAOI simply because these are the only agents that can effectively help these patients out. So it is something we need to be aware of, and certainly there is some substantial history that suggests these problems, such as hypertensive syndrome. Okay, so I think I'm going to cut it off there. I think we've covered the major implications of MAOI therapy. Again, this is more for a paramedic focused, pre-hospital focused. So I'm not talking about dosing or prescribing or anything like that. It's like, if somebody's on an MAOI, what are some common examples of MAOIs, and what are the major things that we need to be on the lookout for? And I think we've covered that. Okay. Hopefully you guys enjoyed the video, and we will see you in the next one. Take care. Bye-bye.